Thanks, Claire. People can see my screen? Excellent. I'd like to begin by acknowledging the rest of the team, Amani, Kate, who are both here, I think, and also Jessica as well, and also acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional owners of the land from which I'm presenting this afternoon. So our research was related to informal learning, and it's a term that we hear a lot in higher education without necessarily talking a lot about what we mean. It's an idea where the mechanics are not well understood either, and it was these reasons that led us to be interested in doing our research. However, it also posed challenges for us because we needed to be clear on what we meant in terms of informal learning to do both our search and analysis. And to that end, we found the work of Goffman particularly useful. And Goffman writes about a theatre metaphor to describe public and private behaviours, and talks about front and backstage communication. And so front stage communication is communication that happens to an audience. If we think about that in healthcare, that would be with our patients or to other team members, maybe by the bedside. But there's also backstage communication that happens that's more private and doesn't have a performative element to it. And so those backstage communications potentially lend themselves to more honesty and openness, whereas a front stage communication might be more about preserving credibility and saving face. And so when you map those front stage and backstage communications against formal and informal learning interactions, you come up with the matrix that I have on the slide here. And we were particularly interested in this grey area where ad hoc, spontaneous learning interactions meet a backstage audience. Our search resulted in 35 papers, and our three-stage analysis identified these 5 themes. The first theme relates to understandings of informal learning. The second relates to the content of informal learning. The third, where and how informal learning might happen. The fourth, things that enable or threaten informal learning. And the fifth relates to the capabilities and dispositions that not only learners might need, but also educators to help make learning in the informal space happen. Now, what I've tried to do on this slide is to summarise some of our key discussion points because there's a lot with 35 papers. We found in terms of understandings of informal learning, there were a range of scholars that people were drawing on, if they were drawing on any form of theory at all. So some of the literature that people were drawing on related to self-regulated learning, communities of practice, student-led learning and peer-assisted learning. And that was despite us having our very well-defined theoretical underpinning to the study as well. We found that it seemed that certain content lent itself to informal learning, or you could look at it another way, was being left to informal learning. So things like professionalism, ethics, identity development, self-care, and political structures in healthcare. In terms of where informal learning happened, it's unsurprising given the types of courses that we deliver that there was a focus on work-based learning environments, but we also saw a growth in online learning spaces and, interestingly, a limited focus on on-campus contexts. So that might be an area of untapped potential or a missed opportunity. Apart from interprofessional literature or interprofessional education literature, we tended to find that students were often left to their own devices in terms of informal learning. So there was a bit of an assumption that students knew what their learning gaps were, what they needed to do and how to go about it, that they did that, and that they were successful as well. And so the enablers and the barriers that we've identified could be useful in helping learners be supported more in the informal learning space. And another key discussion point or a question that arose for us is who drives informal learning? Is it the students, the educator, or both? And what sort of capabilities and dispositions are needed? Certainly for students, agency was a key one. And finally, in terms of future research that we've identified, none of the studies were concerned with outcomes of informal learning, so that's an area to explore. Student perceptions of informal learning. There seems to be connections with professional identity development, and there's a whole host of equity and diversity issues here as well. Thank you.
Thank you very much, and hello everyone. You can hear me okay and see my screen? Excellent, thank you. So I'm speaking to you from Flinders University in Adelaide, and I just wanted to include a shot of our beautiful glossy ibis feathers, which stand sentinel over the campus. I think it's a lovely idea. The name of this work by Judy Watson is Yara, and it means two-way learning. And so I thought that might be fitting for today. So teaching the intangibles of practice. Now, this notion speaks directly to the issue of preparing our future health professions workforce, whose working contexts and experiences will be increasingly conditioned by volatility, uncertainty, complexity, and ambiguity, or VUCA. That term actually comes from the military, but I think it applies. And we are, I believe, somehow obliged to our graduate students to support them to responsibly practice and lead in this VUCA landscape as thoughtful, creative and critical thinkers, cognizant of that iceberg of unstraightforwardness that we have hitherto covered up with our carefully managed curriculums. And we are, I think, with those, with the best intentions, signalling a simpler world than they will actually encounter in reality. So my thinking on this, quite philosophical, but it's spun out of some very practical evaluation work that I did last year, evaluating the rural program of the Doctor of Medicine here at Flinders. And the details on the actual work are in the abstract booklet. So, one of the outcomes of the report, the evaluation report, was the adoption of the principle of experience-led learning, which starts with people's actual experiences, so people being students, clinicians, and patients, and uses these to catalyse learning by anchoring them to relevant frameworks, elaborating with diverse contexts and perspectives, and identifying what else is needed to support understanding. So the experience-led learning framework effectively starts with tangible observations and then explores what is underneath, if you like, and cycles that back into practice. So it is the lived experience actually of the clinicians that occupies my thoughts here. And why is this important? Because, as this student told me, what the program is all about is learning to be a doctor. And yet, despite the extended and close working relationship of the students and their supervisors on longitudinal placement, students are not routinely asking what it is actually like to be a doctor. So this seemed to be left more to chance and personality, and certainly wasn't part of the explicit curriculum. But we know that supervisors and educators are already modelling how it is to be, and that students are taking sharp note of what they see and comparing, although without ready access perhaps to those intangibles that will help them make sense of what they are observing. So the question that arises for me is, what depth of learning, of meaningfulness, of real understanding is possible when we shift the lived experience of being a doctor from a position of hiddenness or quietness or chance in the curriculum to one of explicit revelation. So in fact, the framework for learning how to be is already in place as role modelling, which is described by the Australian Medical Council as the conditioning influence of practitioners on the student, conveying standards of practice that are consciously and unconsciously adopted by the students. Indeed, the AMC values role modelling as a learning method, but in order to move role modelling from condition to method, we need to invoke deliberateness and explicitness. But how deep shall we go? Are we brave enough to be whole person role models, human beings first, who can guide our trainees by showing them what it takes to be and to do an increasingly bigger world as part of professionalism and indeed as part of the clinical practice skill set? So there are 6 suggested strategies that came partly out of the evaluation and partly out of some research in the literature. One is pretty obvious: providing real life examples to the students, sharing one's own ways of seeing, prioritising learning and dealing with the unknown, integrating perspective taking and multiple perspective taking, including those who aren't there. Performing think aloud protocol during the actions that you're taking, and including those kind of silent thinking that you do behind the moves. Pointing out the context for your practice that might have a basis that is not obvious, and allowing unstructured time so that these things can be explored. So can the clinical education curriculum be reframed, not as content to be covered, but as a lived practice to be uncovered, if you like? I think yes, but it requires 2 commitments from both the educator and the student. One is to comfort with uncertainty. Uncertainty does not sit easily within the paradigm of the medical education course, where assessment and teaching are geared towards outcomes that can be confirmed and measured, and where not knowing or not being sure can be interpreted as a deficit of learning. And a commitment to intellectual candour as well, which is really a service of intellectual and professional generosity and a pedagogical gift of deep and lasting value. To simplify even further, we can think of all of this as learning, teaching, and supporting teaching in a milieu of radical openness. So thank you.
Okay, just to start, so I just wanted to start by acknowledging the traditional owners on the lands on which we're coming together today, and pay my respects to any Aboriginal and Torres Strait Islander peoples here with us. So it's my great pleasure to really be presenting this research to you today on behalf of my terrific team, led by Associate Professor Fiona Kent. So in 2017, our collaborative practice or interprofessional practice competency framework was developed here at Monash Uni after quite a lengthy consultation process, which was guided by an internal interprofessional working group, which was established with representatives from across our faculties of medicine, nursing and health sciences, and the faculty of pharmacy and pharmaceutical sciences. Since that time, a number of learning activities and assessments have been introduced to our various health professions programs in these faculties. However, after 5 years of implementation, it was deemed to be time to evaluate our framework and its impacts on graduate readiness for working as collaborative practitioners. So in our research project, we sought to answer 2 questions. Are health professional graduates ready for collaborative working, and has a purpose for curriculum framework contributed to facilitating work readiness? And this first question has been answered in our published paper in Nurse Education Today, so that's my not so subtle plug for that one today. And our second question really centred around in what context does interprofessional learning occur, which is the focus of this presentation today. So in this research, we applied the SIP evaluation framework, where we had multiple sources of data around our areas of context, input, process, and product. So it's quite a detailed evaluation framework, but for the purposes of today, what's important to note is that in terms of this product part, we interviewed graduates approximately 6 months post-graduation from our various courses and their supervisors. So we conducted a total of 24 interviews with graduates and 18 with clinical supervisors from across a variety of professions, as you can see there. And through framework analysis, we found that interprofessional learning occurred across 3 contexts. So learning at the university, learning in the workplace, and learning after graduation. So firstly, to learning at the university, which really centred around activities which were quite formal, if we're going with this language of formal and informal today. So focused on establishing foundational knowledge around graduates' roles, and the roles of other health professions in a patient-centred care team. Face-to-face learning activities involved interprofessional learning days with case study-based discussions, for example, with cohorts of students across our faculties. So these were often focused on what we would like to consider to be authentic or quite organic combinations of students, where I mean that we didn't have every health profession represented just for the sake of it, that we did actually have what we would call natural pairing. So for example, having our nursing and paramedicine students coming together in sort of a real life scenario. There was a mixture of face-to-face learning activities, many of which transitioned to online during COVID. And then we also had our planned online modules earlier on in the courses. So we would consider these to be quite formalised, quite intentional learning opportunities for our learners. Unfortunately, many of our graduates couldn't recall some of the online modules that they'd done earlier on in their courses. But key learning was also identified as occurring within the workplace during placement or work integrated learning opportunities. And so these experiences were often incredibly meaningful and authentic for graduates. However, they were often inconsistent or quite ad hoc and informal, dependent highly on the actual workplace, sometimes around an individual supervisor's own practice and the priority they gave to interprofessional practice, and giving those opportunities for their graduate or their learner to explore other health professions within the team, or an actual graduate seeking out those opportunities during their learning for themselves. So learning experiences, when present, occurred through a variety of activities, which included shadowing of other professionals, team meetings, and dialogue with other health professionals where possible. So leaning into what Sarah mentioned earlier, some of those corridor type conversations, those ad hoc conversations as well. And graduate experiences with collaborative practice were really varied, and as I said, highly dependent upon their profession's specific roles within that specific placement context at that time and the expected outcomes of that placement. And then finally, a considerable amount of interprofessional learning really occurred after graduation. So it was found that interprofessional work was highly contextual, as we talked about during their placements. Upon graduation, supervisors really expected that graduates would have just a basic understanding of the roles of other health professionals, but that context understanding would come with time in their workplace. And that they really wanted them just to be able to refer to other clinicians as appropriate, and escalate conflicts as needed. So what this has really reinforced for us is that there is a continuum of interprofessional learning, and as we look to the future, what we really need to invest greater focus is into the informal learning that we know is occurring in the workplace. So leaning into some of those mechanisms that Sarah's also talked about. In doing so, we hope to empower educators to value interprofessional practice and teaching, but also supporting our learners and educators with a focus on those authentic and meaningful assessments, and in time revise our framework here at Monash University also. So thank you very much.